B. Lawal to please lead us in an opening prayer.
Good evening, everybody.
Good evening,
Can you hear
ma'am.
me? Yes.
Yes, we can hear you, ma'am.
Okay. We thank Almighty God for bringing each and every one of us together this evening. We pray that whatever we are going to discuss will be very fruitful to all pharmacists and all consultant pharmacists in particular. May God help us, give us long life, good health, and prosperity. Bismillah in Athena. Thank you very much. May Allah accept the prayer.
Amen. Thank you very much, ma'am. That's a
Amen.
wonderful prayer, ma. And without wasting further time, I would like to specially acknowledge some key personalities in our midst. In no particular order, I would like to welcome specially all NEC and council member of the Pharmaceutical Society of Nigeria, all CPAN NEC and council members, all executive of technical and interest group in our midst, fellows of the Pharmaceutical Society of Nigeria and West African Postgraduate College of Pharmacists, all members of ASOCLIP, which stands for African Society of Clinical Pharmacy, all other invited guests at this meeting. Everybody, you are all welcome.
Why did he wait?
Dr. Rita, can you unmute? Yeah, unmuted. Dr. Rita, can you unmute and continue?
Oh, sorry about that. Thank you, sir. So I welcome us all in this very special way, and would like to recognize some very key personality in our midst today. And in no particular order, we'll be recognizing all the NEC and council member of Pharmaceutical Society of Nigeria, all NEC and council member of CPAN, all the executive of technical and interest groups in our midst, fellows of the Pharmaceutical Society of Nigeria and WAPCP, and members of ASOCLIP, which stands for African Society of Clinical Pharmacists, all our various invited guests, you are all welcome. Tonight, we'll be looking at a very, very interesting topic, which is consultant pharmacists in today's healthcare dynamics. Renounce the past and announce the future. And I think this particular topic we'll be looking at today is quite apt, in the sense that by the grace of God, the consultancy cadre is here with us and is here to stay. We give God the glory for that. And we thank in a very, very special way every person that have made it possible, all various organizations. We pray that good Lord will bless this sacrifice of love to the profession, because it has not been an easy battle. And so that's why the topic for today is very, very important, so that we as pharmacists will be able to try as much as possible to keep this new era and this new light in the pharmacy profession, to keep it burning. And so the Education Committee of CPAN has deemed it worthy to have one of our very, very renowned professor to deliver the lecture for tonight's presentation. And he is a professor that have various publications to his name. He is a formal dean, and he has been one time Secretary General of the West African Postgraduate College of Pharmacists. He has served as external and internal supervisors to masters and PhD students. And so we have the singular honor to have our erudite scholar in the person of Professor N. Wanang to please deliver the lecture for tonight's clinical meeting. Prof, sir, you're welcome to make your presentation, sir. Thank you.
Thank you very much, Dr. Rita. I want to thank you one and all for coming. I want to particularly thank my Professor Wilson Erum, whom I have seen online. One-time Secretary General of African Postgraduate College, one of the founding fathers of this consultancy cadre that we're talking about, and one of the fighters to see to the fruition of this cadre. I hope my screen is seen. Can you see it?
Yes, sir, we can see your slide, sir.
Can you see it?
Yes, we can see your slide, sir.
Oh, okay. Thank you very much. Thank you very much. First of all, I want to appreciate CPAN. Sometimes back, I got a call from Ivy, and she mentioned to me that they wanted me to have a chat today. It was to be yesterday, but I shifted it till today because yesterday I had a long meeting and presentation and classes at my PG school, so I couldn't make it. I want to appreciate all of you for coming. I want to also appreciate those from other countries, the Francophone, the Lusophone, for joining. And I want to apologize. I cannot speak in Lusophone nor Francophone. This communication is going to be in English. I want to again appreciate the presence of my students. My students in West African Postgraduate College of Pharmacists. I also appreciate my students from the University of Jos, and most importantly, my students, my recent graduates from Afe Babalola University. I can see Afonja and some few. I appreciate you all for coming to participate in this great occasion. That is how we start. What you are doing today is the beginning of the foundation of your career. When you join the profession and you develop interest in developing yourself by participating in conferences, participating in workshops, participating in seminars, you will see that you are going to be a different person in practice. And that is just what you have displayed today to have joined in this meeting. Well, the topic is quite dynamic. The topic is quite controversial because when we threw the thing online, a lot of persons were not comfortable with some words. But of course, it's not everything that you'll be comfortable with. There is this saying that if you want to succeed, you don't need to please everybody. The secret to success, nobody knows, but the secret to failure is to please everybody. So the topic may not be pleasing to everybody, but this topic, we shall look at it today. The keywords are consultant, healthcare dynamics, renounce, and of course, you announce. Let's pick it one by one. Consultant. Who is a consultant? Looking at pharmacists, a consultant pharmacist cadre actually is not strange to the world. It is not a new invention. Consultant pharmacies effectively operate in Taiwan. They operate in South Korea. They operate in Australia. When you look at these three countries that I've listed, these countries are rated among the best healthcare systems globally. There are other major countries that have consultant pharmacists. We have Spain, we have Oman, we have Austria, we have Japan. All of them have long embraced the consultancy cadre, and they have been doing very well. They have embraced the collaborative stance where all the professionals are brought together with the patient safety in mind, and the healthcare system are incontrovertibly a source of envy to most other countries, especially if you're discussing about the patients and the society. In essence, consultancy cadre has existed in other countries, and those countries are doing exceedingly well. But let me give you a little background on the history of consultancy. Probably that is going to help you a great deal. Consultancy is a word that had been used long, long ago. So sometimes when I find it crazy when the physicians at the point were saying pharmacists cannot use consultancy because it is sacrosanct to them and probably is going to be confusing in hospitals. That is a big, big error, Because even the term consultancy did not really start with the medical doctors. Consultancy is as old as history, dating back up to the 18th century. The first people to describe themselves as consultants were actually engineers and architects and law. They were the people that started the consultancy firm. But again, in the 18th century, these consultants were actually the entire firm, a collection of persons as a firm. But the modern consultancy, dating back up to around the early 20th century, the first person to call himself a consultant as an individual, incidentally, is a chemist. He was in Boston, Massachusetts. His name is Otto Little. Otto D. Little, incidentally, if you remember your chemistry very well, he pioneered the application of cellulose acetate in artificial silk. After Otto Little, who is a chemist, then came another person, an engineer, and that is Booth Allen Hamilton. Allen Hamilton became a consultant, but this time around is in engineering. In fact, the AI that we're excited at today was pioneered by Allen in 1914. So this brief story I've told you tells you that to be an individual and a consultant did not start with the medics. It started with the chemists and the engineers. But over time, industrialization came in, technology got advanced, globalization came in, an increase in complexities came in, and medics now picked on developing, and of course, they became consultants. Not to say that medical consultancy never existed, it did. It existed. But dating back to who becomes an individual consultant is not sacrosanct in medicine. The sacro is not sacrosanct to medicine alone. Any other profession can be a consultant. Because if you remember too, in those days, at ancient times, the apothecaries and physicians were described, they started the consultancy, they offered consultancy. They were diagnosing, they were treating, they were offering counseling to patients. Having said this, you believe me that, of course, the apothecaries, we know very well that they are more of herbalists too, or pharmacists, or at worst, they could be pharmaceutical precursors. So you can classify apothecaries, their activity as consultancy, of course, as what pharmacists do. Having said this, it is proper to now know who is a consultant, what is consultancy, how do you operate as a consultant, when do you discharge your duties? So many questions surround and abound the role of a consultant in the society. Now, let's take a look again at the healthcare dynamics in Nigeria. If you say healthcare dynamics, it is actually a complex scenario. Nigeria, we have pharmacists, we have physicians, we have nurses, and we have auxiliary staff, all brought together in one section, and that is the healthcare complexities that we're having today. And of course, the war had been very, very long. The healthcare system in this country is such a confusing situation. Unfortunately, the physicians have dominated the scene, and they seem to be truncating the advancement and growth of other professions. I could remember a particular case when the Nigerian a medical laboratory scientist took the enemy to court. And in court, this was also quoted in the article written by West African Postgraduate College in Nigerian chapter in response to enemy. And in that court, a certain Justice B.E. Adejumo, who was the president of the Industrial Court of Nigeria, said, a profession can only be so called, I quote, a profession can only be so called if it has independence of existence, and a profession cannot have independence of existence if it is tied to the apron strings of another profession by means of supervision and authentication of its work. That seemed to be the situation pharmacists faced at a point, because physicians attempted to dominate the growth and development. Physicians attempted to tie the apron of pharmacy practice into their own domain. And that was a very complex situation. Of course, the medical laboratory scientists celebrated the case the one. The same justice went further to say, and I quote, each profession is autonomous in its own right. Each is equal to the other. Equality of treatment of employees is a cardinal principle of modern employment practice. He went further to say, as no person has a vested right to enslave another. That judgment was passed in 2016. It is so clear and explicit. Now, let us quickly see. Another case, this time around, was in 2017, and with a different justice, Justice Oruwasegbe, who said, and I quote, I venture to say that totally subjecting members of a different profession to the whims and caprices of another is a classical form of unfair labor practice and modern slavery, which cannot produce industrial harmony in any place of work in this modern time. Well, I've just given you some instances whereby we have a lot of complexities in the hospital services. But when I sit down and look at it, I will say, who is to blame? Do we really look at one sector, one profession dominating the others and conclude probably there are some mistakes too that we are making that is giving them the edge that we're having? Let me go further. The controversy of renouncing came in on social media. I deliberately made this, we have to renounce the past and then we announce the future. Of course, when you want to change your attitude, you are not renouncing the old practice, but you are renouncing a behavior in the old practice. That behavior was not taught in school. That behavior was eventually discovered or probably introduced along the practice line, which unfortunately overwhelmed the practice. So we are renouncing that portion of that behavior that overwhelmed the real practice as taught in universities. And we are announcing a new evolution and a new revolution, meaning we're moving from the past to the future. Like what J.F. Kennedy said, those who look only to past and present are certain to miss the future. This is time for us to communicate and see. We need to renounce the past and announce our future. Looking at the slide before you, to the left, where my cursor is, was Lagos. Nobody knew that Lagos could change. The first time I visited Lagos in 1984, I never believed that Lagos will ever change. Come to think of it, Lagos now changed, became organized the way you are seeing it, where my cursor is. And I can tell you, there are plans also to look at Lagos as a feature town like this cursor you are seeing to the right. For you to get this, you have to renounce the former Lagos that you knew, which some people at this stage will say there's nothing wrong with it. Accept that a better future is on the way and you now can announce it. Remember, if you want to learn, you must first of all unlearn the past. Okay, having said this too, like I said earlier, the secret to success nobody knows, but the secret to failure, we all know. In practice, as consultants, as clinical pharmacists, have we ever considered medication optimization? Have we ever considered cost effectiveness? Have we ever considered to give guide as experts? If it is so, then we can confidently say, yes, we are professionals. But not just being professionals. Are we truly practicing and working as consultants? The West African Postgraduate College of Pharmacists, the WPCP, is what bettered the consultancy cadre. The establishment of consultancy cadre is a progressive and essential step towards embedding highly specialized pharmaceutical experts within different multidisciplinary healthcare teams. These highly skilled pharmacists, they possess advanced knowledge and skills that significantly enhance medication management enhance stringent patient safety protocols, and similarly optimize overall therapeutic effectiveness. The specialized knowledge and skills of consultant pharmacists is critical in areas that have specialized knowledge, and the skills of these consultants in advanced management, in pharmacokinetics, when we're discussing dose adjustments and dose titrations, which we can do those things based on laboratory interpretations and pharmacodynamics. Have we ever thought, as we move around as consultants, as experts of genomics, have we thought about meticulous therapeutic drug monitoring? And I'll tell you, if we in pharmacy do not consider pharmacogenomics, do not consider therapeutic drug monitoring, we have not started the work of consultants. We have not gone into consultancy. Because the bane of the consultancy is when you bring in pharmacogenomics, therapeutic drug management, medication management, bring in your knowledge of pharmacokinetics, and you demonstrate this in patient safety. You demonstrate this to optimize treatment outcomes. And of course, you also look at how you can drastically reduce medication errors, drug resistance, and treatment failures. If you cannot bring all this together and not forgetting cost effectiveness, then we have a long way, we have a long battle to go. And I'll tell you, your presence may never be recognized as such, because these are the areas of expertise that you should show as a consultant pharmacist. Ordinarily, a pharmacist does clinical pharmacist, which you have PharmD now, does plenty of those things we do. But what do you do as an expert? I give kudos to WPCP again for cracking different faculties to have different areas of specialization. I, at this juncture, must appreciate the efforts of Professor Erum, effort of Professor Opara for initiating that. And my humble self, I was one that picked up and then started the consultancy career at the WPCP. That alone was a guide, was a direction for us to see how best we can achieve all these factors that are monitored to you. But till now that I'm talking, we have a wide gap in pharmacogenomics, a wide gap in therapeutic drug monitoring. Most importantly, pharmacokinetics is suffering in our ward rounds, in our drug rounds, or in our grand rounds. As consultant pharmacists, can we really consider bringing in these factors now into our practice? As a consultant pharmacist, do you render pharmacy consultant services in your place? Come to think of it, do you take part in medication therapy management? Do you participate in pharmacovigilance, in risk management? Are you involved in regulatory compliance? Do you do pharmacy operations and management? Do you really participate deeply in it? In all we have been talking about your participation, what is evidential about it? Have you conducted a research? Have you developed any manuscript in your practice at your place? Have you sent your manuscript for others so that others can read and know what you are doing? As consultant pharmacist, what have you done to sustain your rank and status? We have somebody that is in Lasut, Uyewale, who is very pronounced in renal pharmacy. She is so known in renal pharmacy not because she's passionate about it. She walks into the place, she knows in and out of renal pharmacy. Why? Because she developed interest and passionately went into it. When we talk about antimicrobial stewardship, Onodogu Chineye is so passionate about it. When you talk about critical care, Maureen Warford is so critical about it. Moise Babalola is so passionate about that. Can you also, as an individual, do any of such? If we discuss pharmacovigilance, you look at Rachel Odesanya, passionate about it. As consultant pharmacists, I'm mentioning names for you to see so that we could pick up mentorship from there if you are coming up. There are several other areas. We can get somebody that is very passionate, renders the real services that are required in all these areas. Can we be one? Is it possible? If you are, then you are moving towards that consultancy pharmacy. You are renouncing your previous behavior and announcing that, yes, you are right, you are going to walk towards pharmacy. Please begin, start. Never be afraid. Some people get frustrated, self-induced frustration. Never be afraid to start something new. I've made this quotation somewhere and I want to say it again. When you remember that the ark built in the Bible was built by amateurs, but of course it saved millions. But the Titanic was so built by professionals that claim that they knew, and yet you know the history of the Titanic. Don't think that you are starting something that is very strange or alien. As Nigerians, as people in West Africa, consultants, pharmacists had long started in other places, but the only thing is they were not afraid to start it. They are not afraid to start something new. You just know yourself, believe in yourself, trust in yourself, and of course, go head on to approach the consultancy pharmacy phenomenon. Please note, for you to be successful as a consultant pharmacist, you must remain a student. You take it or leave it, you read. One of the major problems we have in pharmacy generally is our lack of interest in reading. And that explains why very few people, only in the academia, are consistent and abreast with contemporary issues, with new developments. But the older pharmacists seem not to be bothered about reading. Please, you remain a student. When you look at the medics, the consultants, medical students, the students of their postgraduate college, you go to the hospitals, pick a patient folder, go through it, read, and then you are at liberty to go to your house again and then reconcile with what you have read in books and then go to your drugs and read. Once you do that, your next meeting in that ward, whether you are meeting physicians, whether you are meeting consultants, whether you are meeting laboratory scientists, your knowledge of participation is going to be absolutely different. Today, I am a professor of pharmacology. I'm a professor of clinical pharmacy, clinical toxicology. When I walk into any ward blindly, without having a prior knowledge of the situation, I will definitely not submit much information as somebody that read about that patient the previous day. So please, if you want to be a successful consultant pharmacist, you must remain a student and consistently be reading. Those names I mentioned to you, I'll tell you, they still go back again and make consultations with their books. There's a popular saying that says, they fear those with knowledge and control those without it. When you don't have knowledge, you are going to be controlled. And that's why you have house girls, house boys, security men that you control because they lack knowledge. But once you are knowledgeable, you are being feared by people. Unfortunately, we are in a situation where our adversaries are many in the system, especially in the hospitals. There's a saying that says, when you live with vultures, try not to die. Unfortunately, we are surrounded by vultures. Please let us try not to die. Let us add to our knowledge. Let us continue to read. Let us continue to educate ourselves. At this juncture, I want to give an example of Dr. Ali Kolawole Chinedu Thomas. I'm being careful to cover the Nigerian sector of the Hausa, the Yoruba, and the Igbo in one name. Dr. Ali Kolawole Chinedu Thomas, at the end I will just refer to him as Dr. Thomas, has a PharmD and is a fellow of the West African Postgraduate College of Pharmacists. Now, Pharmacist Thomas, or Dr. Thomas if you want, listen to this story very well. Dr. Thomas had been serving his community for over a decade. He earned reputation for his dedication and expertise. One day, a patient, Fatima, came to the pharmacy with a prescription for a blood thinner. Thomas noticed that Fatima was already taking several medications, including antibiotics that could interact with the blood thinner. Now, I've just given you an example of a pharmacist who is very diligent and performing his own duty. What happens to this colleague of ours? What has he done? Intervention. What has he done? There is interaction. Thomas promptly contacted Fatima's doctor Informing him of the potential interaction, the doctor appreciated Thomas's diligence and adjusted the prescription to minimize the risk. This intervention prevented the potentially life-threatening bleeding complication. This is a very simple action that Dr. Thomas did, but he had displayed professionalism. Two things are here. He was able to discover drug interaction, and he was able to have an excellent communication skill with the doctor. That is the kind of relationship that you consultant pharmacists should do. On another day, the same Dr. Thomas had another patient, Oluwale. Oluwale was prescribed a medication for diabetes. Thomas reviewed his medication history and realized that the dose might be too high because of Mr. Oluwale's kidney functions. Thomas consulted the doctor, and together they adjusted the dose to prevent potential kidney damage. Again, Thomas has shown expertise. What did he do this time? Dose adjustments. What did he do? Knowledge of pharmacokinetics. What did he do? Knowledge of interpretation of laboratory parameters. He looked at it and realized that the kidney was not responding well, and he quickly alerted the physician. These are the kind of things that experts, consultant pharmacists should be participating in our hospitals. Let's look at another medication counseling by this same Dr. Kolaole that we know. A young marketer in Kichi came to the pharmacy with a prescription for a child's asthma medication. Thomas took the time to counsel Nkechi on proper inhaler use, potential side effects, and the importance of adherence. Nkechi appreciated Thomas's guidance, which helped her better manage her child's condition. How many of us take our time to counsel our patients as consultants, as experts on potential dangers? How many of us counsel our patients on medication use? How many of us counsel our patients on drug adherence? I can tell you, Nkechi will never forget Dr. Thomas for helping her in the management of her child's asthma medication. Again, how many of us can identify adverse drug reactions? For instance, the same Dr. Thomas, an elderly patient, Mrs. Dinka, reportedly experiencing dizziness and nausea after starting a new medication. Thomas recognized the symptoms as potential adverse reactions and promptly notified her doctor. The doctor adjusted the medication and the symptoms were resolved. Now, all these individual narrations I'm telling you, Thomas's expertise and vigilance played a significant role on patient care. What he did, he prevented complications, and of course, he improved the health outcomes. His dedication and safe medication use and patient education exemplified the vital role that we can play as pharmacists in the society. Having said this too, we are to create our relevance. Will you want to practice like Dr. Thomas? Will you want to renounce your old behavior, whereby you stay in your cubicle, you count pills and give to patients without perusing through interaction, perusing through drug adjustments, perusing through doing medication counseling, identifying adverse reactions, pharmacogenomics, therapeutic drug monitoring? Are we going to remain in our old behavior, or we are going to renounce it and then announce our new rules? Do we really take time on medication therapy management? Do we know that optimizing medication regimens is very important and pharmacists play a key role in it? Have we been able to identify medication-related problems? Have we been able to dictate issues like adverse reactions, interactions, or duplication of drugs? Have we been able to discuss patient education and counseling? Have we discussed medication adherence with our patients so that they could see the importance of taking the medications that are prescribed? Have we known anything about disease management? Have we given a guide on, especially to patients on chronic conditions like diabetes and hypertension? Have we, as experts, consultant pharmacists, collaborated with other healthcare team members? What is our communication skills? How do we communicate with the doctors? How do we communicate with fellow pharmacists? How do we communicate even with our patients? How do we work with nurses? How do we work with other professionals in the hospital? Most importantly, how do you collaborate if you are doing a research? We, as consultants, have we considered patient safety as utmost? Have we bothered to check medication error? Have we bothered to see how to prevent those errors? Have we double-checked prescriptions? Have we monitored adverse reactions? We, as consultant pharmacists, have we done any public health initiatives? For instance, vaccination programs? Have we promoted immunization? Have we done any significant health screenings? Especially things like hypertension, diabetes, or cholesterol level in patients. We, as consultant pharmacists, have we participated in chronic disease management? For instance, diabetes and hypertension that are commonly mentioned too. What have we done in providing lifestyle counseling to patients? What have we done in monitoring medication adherence as consultants? What have we done in promoting health habits? As consultants, what have we done in medication adherence? Have we ever made medication synchronization? Have we any strategy for pill boxes and also reminders? How have we fared in patient education? How have we fared in preventive care? How have we fared in health screenings? How have we participated in those things? How have we as experts taken part in special populations like the pediatric, the geriatrics? How have we done in patient-centered care, especially in personalized medication plans? When we can answer all this, then we know that yes, we are moving in the direction of actually being consultants, consultant pharmacists. Please, as pharmacists, we must learn to create relevance. Albert Einstein will say, insanity is doing the same thing and expecting a different result. I am not saying we have insane persons in our profession, but because I have another barrage of controversy. But what I'm saying, we have to do things differently so that we announce that, yes, we have arrived and create relevance for ourselves in pharmacy. Al Capone will further say, you are either on the table or you are in the menu. Severally, we have not been participating in functions. When physicians are going on the ward round, we should participate in the ward round. While they are concentrating more in internal medicine and whatever, our attention should be on medication therapy management. Our attention should be on drugs. Our attention should be probably genomics, pharmacokinetics, pharmacodynamics, drug therapeutic monitoring. Our attention should be focused towards drugs and drugs and drugs. I have no business with the pathophysiology in as much as, yes, I was taught, yes, I have an idea about it, but that is probably sacrosanct to their medical line. My business is to apply the knowledge of pathophysiology into pharmacotherapeutics, which is my own area, my own field. It is when we try to delve into the pathophysiology that they may feel threatened that we are leaving our lane and entering their lane. We have a lane that is so clear, so descriptive, and so waiting for us to exploit, low-hanging fruits. Most importantly, we always box ourselves into the corner. We think within the box. Please, after this interaction, after this seminar, I want you to throw away the box completely, throw the box, and then think properly. Please note, if pharmacy is suffering today, if Nigeria is suffering today, we agree that it is because of a lot of complexities. Do you know that most of the hospitals, most of the countries in the world that are practicing best healthcare system, their ministers are not physicians? Nigeria has this, that only those that are physicians are registered with the medical council will be CMDs in hospitals and will be ministers. And that could explain why we are very backward in terms of WHO ranking in health. France, Sweden, Denmark, Austria, UK, name these core countries, all of them, their ministers are not physicians. For instance, the Minister of Health in Sweden, Ako Ankaba Johnson, she read social sciences. The Minister of Health in Denmark, Sophie Lodi, has a bachelor's degree in political science. The Minister of Health in Austria read social works and administration. Her name is Corina Skuman. The Minister of Health in Canada is a nurse, Kamal Kera. UK operates a very stratified system whereby they have different heads. And the person in charge of health and secondary care is a nurse, Karen Smith. The person in charge of state for care, incidentally read English, Stephen Kinnock. And also the person in charge of public health and prevention read politics and contemporary history, Andrew Gwen. I can go on and on to tell you that most of them, if not all of them, are not medical, don't have medical background. However, even in the US, the minister read history and literature. They are not physicians, but the system works. And that is the difference between that system and our system here. I'm giving this background so that you can see, yes, the complexity of Nigeria. Yes, we have a lot of difficulties. Yes, we do not have enough pharmacists on ground. Some people can lament and say, we are not many consultants, not many of us are WPCP graduates. That will explain why I'm not performing my duty. But again, just do it. Alone is many. I am reminded of a quotation which Onodogo also quoted some times back. If you think a single consultant pharmacist is too few to be effective, you have never been in a dark room with a mosquito. If you are in a dark room with a mosquito, that noise of that mosquito perpetually disturbing you is similar to if you are alone as a consultant pharmacist and you do that job effectively as I've described. Once that is done, then you are sure that yes, we are on the way to achieving greatness. We're on the way to create relevance. We're on the way to define the new role of a pharmacist, and we're on the way to announce the future of a pharmacist. Please remember, light shines brightest when surrounded by darkness. We are surrounded by a lot of adversaries. We are surrounded by darkness. As consultant pharmacists, graduates of WPCP, as clinical pharmacists, members of CPAN, we can practice differently, even amidst the darkness. We are going to shine brightest. Please note, when Julius Caesar, those of you that read the great book of Julius Caesar, you know this quote, he came, I saw, and I conquered. It was the ancient Roman general and statesman Julius Caesar who made this famous comment, Veni, vidi, vici. I came, I saw, I conquered. Here, I must acknowledge people like Folatayo, Professor. I must acknowledge people like Cecilia Iguilo, Professor. I must acknowledge people like Femi Oyewo, Professor. I must acknowledge people like Dr. Chijuki and myself. I could remember not once, not twice, when we were secretary, we would go to the front and move backwards, go to the front and move backwards, until we devised a strategy that we have to keep everything quiet, because the more we talk about consultancy care, the more the frustration goes run around. I could remember a day that I went to Abuja from Lagos twice in one day. I could remember a flight that these 5 names that I mentioned toward to Abuja to press every necessary button for the consultancy cadre to come to fruition. So I can rightly say, yes, these people are the founding fathers. And one thing you should know, all of us that struggled for this consultancy cadre, none of us is going to financially benefit from it. But we did that for the younger ones. Why I'm giving this narration is, you may think what you are doing is not going to be noticed. Do it, even for the sake of protecting the profession, for the sake of managing and helping the profession to grow and develop, for the sake of the younger ones, so that when they come, they should inherit a practice free. They should inherit a pharmacy practice that is devoid of difficulties, devoid of complexities, devoid of any adversary. A pharmacy practice that you can hit yourself and say, yes, I was part of the system that developed this level. And that is why each time I'm talking, I appreciate people like Professor Erum and Professor Para, who laid a solid foundation in WPCP. Folatayo, Igwilo, Femi Oyewo, all of them have one time been Secretary General of WPCP. They laid a very solid foundation, which I came and built on to get where we are. And then, of course, built again by Professor Ibrahim Uriagba. All of us, we came, we saw, and finally we have conquered. In practice today, you are our light. You are our mirror. As you come, you will see. And I pray that at the end, you will conquer. For me to thank you, I want us to end with this quotation. a prepared man is a prepared mind. And a prepared mind is the beginning of success. As we end this discussion, Dr. Rita Ocheredi, remind us again to prepare our mind to be consultant pharmacist. When we are prepared, our mind shall be prepared, and that's the beginning of success. And we shall be heralded as consultant pharmacists. And whatever happens, nothing in hospitals will be done without the presence of a consultant pharmacist to help, to guide, to improve the safety and health management of our patients. I thank you very much for your time once again. Thank you for your patience. It is late. I wouldn't want this lecture to drag more than 1-2 hours so that we can rest. I don't know whether you allow questions, but with your kind permission, please, you can go ahead to ask questions. Thank you so much, Dr. Rita. Over to you.
Yeah. Thank you very much, sir, for your well-detailed and self-reflective lecture for today. It's always a delight to always listen to you. I was once your student, and I always look forward to your lectures in class because I know there will be a whole lot of pictures and lovely quotes to actually buttress your points. We thank you very much, sir, and the lecture has been well delivered, and we appreciate you telling us some of the vital roles we play in the society to actually make us relevant as consultant pharmacists. They were really numerous, but some of the ones I pick, and I know that we can work well with as consultant pharmacists and explore you mentioned about therapeutic drug monitoring and pharmacogenomics, resolving adverse drug reaction, drug resistance. And you actually pointed out some mentors, which I can actually attest to, that are really doing us proud as consultant pharmacists. We really thank you very much. And I think it is really self-reflective as it is. And we are all charged up tonight, to renounce our past behaviors and embrace and announce our vital role we play in the healthcare team. We are going to go out there to collaborate with other healthcare professionals, and they are going to see our relevance as consultant pharmacists and better appreciate us in the society. We thank you very much, sir. And it's now time for questions, contributions, comments. If there are any, you could just signify by raising up your electronic hand, or you can drop any of such questions or comments on the chat box. We are going to acknowledge them accordingly. Thank you very much. Okay, we have pharmacist Ijoma. Okay, Ekurum. Please unmute yourself and make your comment, question, or contribution. Thank you.
Yes, thank you very much. I must appreciate and thank Professor Wanang, who is a delight to listen to anytime, any day. Very knowledgeable, sagacious. I continue to connect with the vibrancy he brought with his secretaryship of the West African Postgraduate College. And I thank him so much for all that he did when the Port Harcourt Center was started. I also commend Professor Eru, who is a teacher and mentor anytime, any day. I commend all the sacrifices all of them have made. I want to support what Professor Wanang said about the headship of the Ministry of Health. And it wasn't so in Nigeria. What is happening presently came with the uttermost corruption that is bedeviling our country. The Ministry of Health take its inception in 1957. And from 1957 to 2007, Nigeria had 18 ministers of health. Out of the 18 ministers of health, only 7 were physicians. 11 were from teachers. Somebody like Aminu Kanu, we knew, of blessed memory, we knew was a teacher. Somebody like Julius Adelusi Adeluyi, we know is a pharmacist. Somebody like Eyitayo Lambo, I think is an economist. And even ABC Nwosu, they were not physicians. But from 2007 till date, the rest 7 ministers of health are all physicians. That was during, I think it was during Jonathan's time, that the NMA had their greatest sway and then used the Buhari and the present government to institute and legalize their emperorship. So it is corruption. And they finally smuggled in a clause that said only medically qualified. So I think we've been advised to, go to court because it's discriminatory to say that one who belongs to a system cannot aspire for the highest office. So I commend all this and also encourage us, until you say I am, nobody says thou art. Let's not take the consultancy cadre as a title, but let us display it in everything we do. But like as I will always say, the greatest motivation anybody will have is when reward and recognition is attached to what you're saying. I'm not a member of CPAN, but I come in once in a while, and I commend you guys for the great job you guys are doing towards showcasing pharmacy practice. Thank you very much.
Thank you very much, Ma, for your commendation and motivating speech, Ma. And so please permit me to ask Dr. F.E. Williams, Ma, to make her contribution or ask a question. Over to you, Ma.
Good evening, my professors, fellows of the Pharmaceutical Society of Nigeria, fellows of West African Postgraduate College of Pharmacists, and others that are here. Thank you so much, Professor Wanag, for this beautiful, excellent, impactful presentation. I didn't expect anything less because of the kind of person you are. We want to really appreciate all the leaders of the present and past leaders of PSN for the fine work they have done to ensuring that the consultancy cadre has come to place. However, there's something I observe with regards to pharmacy that we need to really address. That is, we have a lot of fight within and fight without. Unfortunately, some of our colleagues are supposed to support this fight, even for PharmD. I remember some years ago when we went to Bauchi, University of Benin was the only school of pharmacy that was running PharmD then. Before its recognition, there were a lot of obstacles to ensuring that PharmD comes to see the light of the day. So, Prof, I want you to encourage the young ones, despite the fight within, they should ensure that the right thing is done. After a lot of fights, it will see the light of the day. There's a silver lining to every darkened cloud. So what will you advise if that fight becomes so intense that even pharmacists are the ones that are standing in the will against the will of progress? Please, these young ones and some of us who are old need this encouragement, because sometimes it could be so tiring when you fight and fight and fight, and even people you think you are fighting for are the ones that betray you. Thank you, Prof.
Okay, thank you very much, Ma, for your observations and contributions. Prof, sir, do you have anything to say regarding our comment or contribution, sir?
Yes, I thought maybe do we get out? Let me answer this too.
You can go ahead and answer.
There are some hands up. Can't we just pick them, then we answer?
Okay,
I should go ahead.
Yes, sir. You can go ahead and answer. We'll take them as it
Okay,
comes.
thank you. Well, I want to sincerely appreciate all of you for your questions. Dr. Ejema from Port Harcourt, I appreciate your contribution on statistics excellently. You did well. You see, one thing about physicians, they unite to protect their profession. I pray that we too should learn to do that. If there's any little problem with a pharmacist in Port Harcourt, in Lagos, the PSN of Plateau should be able to rally around and make a press statement and contact other PSN members, and quickly they assemble an action. They are very good at going to court, and that's why they win a lot of cases. That's why their emperorship becomes boundless. They move to go anywhere. Recently, they won a case at the High Court, I think in Anambra State, whereby opportunities, they said you must be medically qualified to be a CMD, but they don't have PhDs, and they want to come and teach, they want to come and be a vice chancellor in a university environment that gives awards a PhD. Now the controversy. If somebody is not medically qualified, he cannot be a CMD. And remember, CMD is not a professional office. You don't do surgery in your office. You don't consult in your office. It's purely administrative. And yet, they were able to twist government to say you must be medically qualified to be a CMD. Why did they do that? Because they are always together. My people will say, if snakes have been working together as a group, people will not kill them. But because snakes walk alone, that's why you have the confidence to carry stone and face it that you're going to kill it. Believe me, if there were 2 or 3 moving as friends, as a group, people will run. They will not be killed easily. That is the problem we have now. Physicians work as a group, as a team. They work together. Pharmacists do not work together, which is also a part of the portion of Dr. Williams' issue. Let me let me depress you a little. Do you know that the University of Jos, at a point, was offered a big land inside Jute to build their hospital, to build their faculty, rather, pharmacy faculty, faculty of pharmaceutical sciences, University of Jos. Do you know that when we got a grant of about 1 or 1.5 billion naira from TED Fund, when we're about to start building this structure at the University of Jos, at the Jute permanent site, do you know that period, physicians rallied around the CMD, who initially agreed, but was put so much pressure to reject that, no, pharmacy will not come to Jute because pharmacy refused to join them as a college. Do you know that within that same week, the NMA boss, Professor Uja, traveled in the night to Jos and invited all council members of Jute that are physicians, and all of them stood firm that they will never allow pharmacy to come and build in the hospital. Do you know that they were able to go and convince and bamboozle and twist university management, and they succeeded? We, in Faculty of Pharmacy, did our best, attempted, went there and did all the English, and we spoke. But of course, they overwhelmed and refused. Enemy came in. Unfortunately, no professional body, NAPA, they didn't come to help University of Jos. PSN did not come. Probably PSN was not informed. Probably NAPA was not informed. But I'll tell you, information is power. When we have some people will scout for the information. Enemy does that. They are united. That is one of the major problems we are having. No doubt about that. Let me come back to your question, Dr. Williams. Truly, there are so many fights within and without. There are so many fights inside. Even the University of Benin that started FMD, they had a lot of problems. But don't get too depressed. When pharmacy started originally too in the US, you cannot believe it, there was also a lot of infighting within themselves. It is a normal thing. I will end by giving a quotation by Socrates. Socrates said, after the storm comes rain. We have faced the storm. FAMD is now a reality. We have faced the storm. Consultancy CADA has now become a reality. What we need to do now is to how to sustain our relevance in the healthcare system. Let it get to that stage that patients will say they want to see a pharmacist before going home. Let us get to that stage that patients will come to the hospital after seeing their physicians. They will wait and say, no, I want to see a pharmacist. I want to see Dr. Ichom. I want to see Dr. Williams. I want to see Professor Wanang. Let us be that eye, that pillar that patients will come and insist that they needed to see, listen to our last words before they go. I'll tell you one thing in Afe Babalola University. The RA himself, the founder of Afe Babalola, does not do anything without consulting a pharmacist. Honestly, I don't know where he got that that wisdom from. But anytime he has any problem of drugs, health, he will tell the physician, the prescriber, are you a pharmacist? You say, no, please call a pharmacist first. So the pharmacist must be by his side. Whatever they give him in the hospital, he must come and show his pharmacist first. Can we get to that level where our practice will define us? Can we get to that level where our strength as professionals should come from us? If we get to that level, that is when the rain has come. But as for storm, there must be storm. The weather must be stormy. After a stormy weather is rainfall. Those of you that know Socrates very well, his wife was a stormy woman, but he lived a fruitful life, a happily married man, and of course, nobody talks about that, a man of wisdom. That is our portion. That is our plan. We shall continue to weather the storm, but we are looking ahead. It must end in a rain. Thank you.
Yeah, thank you very much, Prof. Sir, for giving us more insights to the various question and contribution made by our participants. And so please permit me to invite the immediate past national chairman of AHAPIN in the person of pharmacist Olabode Ogujomiyo to please make his comment or contribution, sir. Please go ahead, sir.
Yeah, thank you very much for recognizing me. Let me appreciate Professor Wanang for that insightful presentation. I want to believe that all of us have been charged. I also want to suggest, or rather, I wouldn't know the reason why we limited the number of participants, because I saw so many people talking on the platform that they could not actually join the presentation. I wish that we had more participants. It would have been better. But thank you very much for that presentation. I will draw my first strength from one of the statements made by Professor Wanang, talking about the fact that when you are in the dark with one mosquito, you know the implication. What that is trying to explain to us is just that you don't need to have 50 consultants, 30 consultants in a particular facility before our impacts are felt. Only one consultant is enough to be able to make impact and, of course, to be able to take pharmacy practice in that particular hospital or institution to the next level. So the truth of the matter is that pharmacists are doing a lot in the hospital setting. A lot of interventions are being done on daily basis and things like that. Even before consultants were being appointed in the various FHIs at the state level and all that, the fellows of the college have actually been doing very, very well, taking pharmacy practice and, of course, doing the needful for the benefits of the patients across board. Now, coming to the issue of infighting, we are not unaware, sir, that there are a lot of infighting even within the pharmacy profession, in the various institutions, in the various hospitals, and all that. But I just want to use this opportunity to plead with as many heads of departments or as many people that are at the directorate level that are not consultants, that we should actually encourage the younger ones who are consultants, who have also been so appointed, because we see situations whereby people, HODs that are not consultants, will want to debar the younger ones from being appointed consultants and things like that. I think this is the time we need to be more united than before. Let us ensure that this issue of consultancy is entrenched in all FHIs, in all our institutions and all that. And we all know that whatever they are doing is for the betterment of the patient. So I just want to plead with as many people that are in the directorate cadre that are not consultants to actually encourage the consultants and, of course, let them do what they are supposed to do. Then we are not also unawares that most institutions are actually short-staffed. But for us to be able to make impact, we have to go extra mile. Because if we begin to harp on the fact that we are short-staffed and all that, so how will our impact be made? So I just want to plead. It is true that we are short-staffed. We do not have as many pharmacists that we are supposed to have in the various institutions. Even the PCN recommendations are not being followed. We know the number of consultants that we are supposed to have. We know the number of deputy directors, number of interns and all that. But what we see in the various institutions is far cry below what we are supposed to have. So these are some of the things that I think we need to do. And of course, for us to encourage, and like someone said, we need to encourage the younger ones that are just going into the college, that the future is actually bright. And we believe that by the grace of God, pharmacy practice is going to get to where it's supposed to be. I remember last year when we had our conference in Enugu, and in one of the interviews, I said within the next 5 years that I see a situation whereby pharmacy practice is taken to the pharmacists being appointed as consultants and things like that. We all know the reason why some of these the NMA and our people from the other sides are not supporting this, because one, because of our relevance. Our relevance is getting the patients are getting to know our relevance. The whole nation is getting to know our relevance. And of course, because of some other things that impact that we are making in the health sector. So I just want to once again appreciate Professor Wanan for this presentation. All the labors of our heroes past, all that are the people that he has mentioned, the likes of Professor Yewo and all that, all of them are putting their best. The PSN are putting their best. All technical groups have actually supported this course. And by the grace of God, I know that the pharmacy practice in Nigeria is going to be where it's supposed to be in the nearest future. Thank you very much, sir.
Yeah, thank you very much, sir. We appreciate you very much. And we know you also contributed your own quota when you were the national chairman of AHAPAN. Thank you very much. And we appreciate your call for unity and for us to make a meaningful impact as consultant pharmacists. We have a question on the chat box. And
Can I add to that,
some,
Dr. Rita? Dr. Rita, let me add
please
to
go
that.
ahead, sir.
Please,
Okay,
pharmacist Olabode, you
Yes, sir.
pharmacists are doing a lot in hospitals. What evidence do you have? Pharmacists in hospitals don't document, they don't publish.
You are correct, sir.
Your work so that people will read and know that you are doing something. You must not be in the academia before you publish an article in a journal. You have West African Journal of Pharmacy by WPCP. You have Nigerian Journal of Pharmacy by PSN. You have several journals wherever you are. Even if you don't have a journal, the hospitals in that zone, the pharmacists in that zone can come up and create a journal club and develop a journal, even if it is locally produced. All you need to do is consult academia, consult people in the university so that they can help you to superintend over your journal. They help you to become the editors. They help you to give you the tutelage, the process of establishing a journal club. Publish your articles. Physicians publish everything. You treat someone, you cut somebody, blood comes out, you block it, you publish it. You do same. By the time you do this publication, I will sit down in Jos and know that Olabode has been a researcher. Remember, one of the things I mentioned when I was talking about pharmacy consultancy, the last was sustenance and mentorship. One of it is research and development. Where do this fall into? You must not be in the academia before you research. You must not be in the academia before you publish. Please, hundreds of you on this platform, from today, take an oath that you are going to start a research in your place. Research does not mean you must carry a test tube. You must not add sulfuric acid to a leaf to turn green. No. You can do applied research. Seated on your table, you can generate data. Seated on your table, you can have a lot and endless information that you want people to know on pharmacy. Thomas intervened on mere blood thinner, an antibiotic. You can write an article on intervention that you did on drug trials, not you as an individual, but the implication of administering aspirin or dispirin to a patient that will undergo surgery in the next 1 week. Blood will thin. There will be a problem of clotting. Simple. You make your own publication, published by Olabode Ogunjomi or Ogunjomi Miyo. That's all. Who is he, a pharmacist? Please, let us imbibe the culture of publication, manuscript development, publication. Thank you.
Thank you so much, sir. Well taken.
Sorry, Dr. Rita, you can go ahead.
Okay, thank you very much, Prof. And I think you just reminded us of one particular area as pharmacists we have to embrace, making publications, going into research. Thank you very much, Prof. And so there is a question on the chat box, and I think I'm able to summarize it. The pharmacist wants to know how we can showcase our expertise when it comes to parenterals. I think that is what that pharmacist is trying to ask on the chat box. Prof, sir, can you address the question, sir? How we can showcase our expertise when it comes to parenterals?
Okay. You see, Dr. Teresa Pounds created a niche for herself in nutrition. As pharmacists, you can actually create a niche for yourself in parenterals. All you need to do is information generation. All you need to do is search for information about the parenterals, and you can become an expert in that field. In fact, the fields in pharmacy are so wide and varied that sometimes I wonder why pharmacists are saying they want to begin to do injection. I could remember I had an argument one time with pharmacists. They said, why should they stop them from injecting? And in my mind, I said, if you knew the low-hanging fruits that you have left, going to look for injection to inject, this is what community health and social workers do. Why would I bring myself so low that I want to carry syringe and needle and pierce into somebody's buttocks? There are several other fields. Parenterals is one. You can gather information and create a niche for yourself. You can develop it. All those things that we had mentioned on the role of a consultant pharmacist, you can link it to your parenterals. The pharmacokinetics, the pharmacodynamics, the pharmacogenomics, the drug monitoring, all of them you can specifically align them only to the parenterals. That's no problem. No problem at all. Over.
Okay, thank you very much, Prof, for answering the question. And so before we call it a wrap on the section, please permit me to invite the national chairman of CPAN, in the person of Dr. Maureen Wafford, to please give us a vote of thanks. You're welcome, ma.
Good evening, everyone. I hope I'm
Good evening.
audible.
Yes, we can hear you, ma.
Okay. I'm so happy tonight, having listened to our dear erudite Professor Nwanang. Prof, we are really proud of you. Thank you so much for bringing out your time despite your busy schedules. We are very, very grateful. The topic of tonight's clinical meeting, I can say, is the talk of the town. What's happening in the pharmacy profession few months now. And it's time for us to renounce the past and announce the future. I quite agree with this topic. I want to especially appreciate Professor Bola Joka Aina. I saw her on this call. You're always here with us, Ma. We are happy to have you tonight. Also, I want to
Thank you, my chairman.
thank Professor Eru too, our dear daddy in the profession. Prof, we are grateful to have you here with us this night. I cited a pharmacist, Mrs. Fumilayo Oluwa, to me. Retired but not tired, always here with us. She gave it to us a few weeks ago here on this same platform. Ma, we are glad to have you too. I also cited Dr. Meg Obono. We are glad to have you. And my dear IPC, Dr. Olabode Ogunjomiyo, and few others, elders here on this platform. We are glad to have all of you here with us. I just want to add a few more words to what our dear professor said tonight. Specialization is the key. You cannot be a consultant pharmacist without having your own specialty, because you cannot be jack of all trades. Most of all that got this our fellowship few years back, really, most of us don't even have any specialty. Please, this is time for us to narrow our practice down. Go to any part of the clinical pharmacy, any pharmacy practice you have passion for, please stay there and read very hard on that area and make an impact. We must have to narrow our practice down. You must have to. You can't be a consultant in all the field of pharmacy. It's not possible. Please. And now WAPC is now trying to recertify all of us, old fellows, so that you have your peculiar specialty where you're going to practice. Please let us all key in. Let us key into that program. It is still running. You cannot do without specialization. I want to ask those of us who are consultants, have you started your consultant word round? I have started mine every Tuesdays. My unit, they know that. Have you started yours? Are you still just sitting inside the pharmacy, just dispensing? You must have to render this service to our patients, not just asking for the allowance. You must have a day in a week. You must have a day in a week. You do your own word round, consultant pharmacist word round. That is the key now. And afterwards, you have a day to join the multidisciplinary word round and start to train and mentor others. If you cannot start your word round, you've not started doing anything in the hospital. And that's why our dear friends will continue to say we are earning allowance that we don't even earn. I don't think they will say it about, because they know I do my word round every Tuesday and they see the impact. So I want to energize all of us. Start small, no matter, even if you come into the world, just see 1 or 2 patients. Yes, let them say it's pharmacist, it's my consultant. My units, they know. Every Tuesday, all of them, the interns, everybody must try to know our patients at the tip of their finger, because they're going to present those patients to me as a consultant, so that I will now bring in the interventions, recommendation to other healthcare providers. So let us start small. Start today to have just 1 day in a week for your consultant pharmacist ward round. Then before you know it, those are friends say, yes, so we used to see them. They say they are consultant, they're not coming. Yes, it's better than say that we don't earn it. Today is early. Let us denounce the past and announce the future. Thank you so much for having us tonight.
Thank you very much, my able National CPAN Chairman, Dr. Maureen Wafo. We appreciate your reflective comments, charging us to go ahead and go for our ward round and try to specialize in the various practices of pharmacy. Thank you very much, Ma. And I think there are no more questions on the chat box, and there is no hands raised for questions or comments. And so we're going to wrap up the section for tonight's lecture. Permit me to call on Dr. Isibo to please lead us in a closing prayer. Thank you.
Before
very
then,
much.
I want to appreciate those that came from other countries. I can see Cisco, I can see Jalo, I can see some other people from Osaka, I can see Gali, my friend from Niger Republic. We thank you most sincerely for participating.
Thank you very much, sir.
Thank you.
We
Nice
are honored to have you.
It is always a pleasure to be part of you. Thank you.
You have been a wonderful person. Our friends from Liberia, our friends from Sierra Leone, our friends from the Gambia, they are also here.
You're welcome. Nice having you all. So over to you, Dr. Isibo, sir. Lead us in closing prayer. Okay, if he's not on the call, may we have Dr. Anne Imoro to lead us in a closing prayer. Dr. Anne Imoro, if you're on the call, please lead us in a closing prayer.
Can I lead a prayer in Islam?
And then, okay, the name of the Father and of the Son and the Holy Spirit. This evening, Father, we
please go ahead, sir. Please go ahead. Go ahead.
Okay, I'm from Liberia. أعوذ بالله من الشيطان الرجيم بسم الله الرحمن الرحيم الحمد لله رب العالمين الرحمن الرحيم مالك يوم الدين إياك نعبد وإياك نستعين اهدنا الصراط المستقيم صراط الذين أنعمت عليهم غير المغضوب عليهم ولا الضالين آمين اللهم صل على محمد وسلم صلى الله عليه وسلم الحمد لله رب العالمين. Thank you so much.
Thank you, sir.
Good night. Thank you very much, for your prayers. And so we call it a wrap for today's section. And we thank everyone that are brought out their time out of their busy schedules to join us for tonight's very, very interesting and interactive lecture. Do